Hello, my name is Tom Goddard. I'm the founder and chief executive officer of Integral Healthcare Solutions. We're delighted to have you join us today for our webinar on COVID-19's impact on healthcare accreditation. We'll be talking about URAC, NCQA, ACHC, VIPS, and other issues beyond that, including telehealth and staffing concerns. I'm joined today by my colleagues, Lesley Malus Reed, IHS's president, and Sue DeMarino, the chief clinical officer. Sue, tell us about yourself.
Hi, as Tom indicated, my name is Sue DeMarino. I have been with IHS for 4 years. Prior to that, I was at URAC for nearly 17 years. While there, I served various roles, from an accreditation reviewer to director of the program to the vice president of accreditation. I'm really happy to be here with you today to talk about COVID-19 and how it's impacting your accreditation process. Les?
Hi, I'm Lesley Malus Reed, president of IHS, and I started in the Canadian healthcare system, worked for a larger health plan, and went to URAC in 1997 as a reviewer. I've been working with this esteemed cast of characters for a long time in accreditation, and we're very excited to talk to you about today how we've all been affected by COVID in this accreditation world. Tom, I'm going to throw it back to you.
Thanks, Lesley. I have a law degree and a psychology doctorate and have been running IHS since 2002. Before that, I was the chief operating officer and general counsel at URAC, and was also served as a reviewer on over 200 reviews. In addition, before that, I was the general counsel of a health plan, and before that, I was at the National Association of Insurance Commissioners, and in other ways have been involved with the healthcare industry since the 1980s. Today, we're going to talk, as I said, about accreditation organization responses. And we're going to talk about those responses in a couple of different ways. The first way is we're going to talk about how are the accreditation organizations, or AOs, changing their actual processes. And then the second thing is, what are you going to do if the virus or your response to the virus prevents you from complying with the strict letter of the accreditation standards that apply to your organization? We'll spend a good bit of, in fact, most of our time on those two issues. We'll do a very light touch toward the end on telehealth, because certainly telehealth is in the news now that the need for telehealth has expanded so rapidly during the pandemic. And then finally, we'll talk very briefly about staffing issues that that you may be encountering, and what some of the options are available to you. So as I said, we're going to start with how organizations are changing the accreditation process, and we're going to start with URAC. Sue, take us away.
Well, thank you, Tom. Well, first let's talk about the validation reviews. Those used to be called URAC's on-site visits. What URAC has stated is that until 5/15/2020, there will be no on-site reviews. They are going to try and do them virtually, if possible, and if they can't do it virtually because your organization can't support a virtual review, they will postpone that. And then all of their monitoring on-sites or monitoring reviews that they've been doing that they have scheduled for 2020 are also suspended through May 15th of 2020. My expectation is those dates may adjust as we get further insight from our regulators and the president. URAC will be evaluating requests for extensions of application submissions without penalty. So if you're in the process of seeking accreditation or reaccreditation, they will also work with you, give you extra time. We recently had a client that reached out to URAC and they gave them an additional 30 days. and then told them if they needed additional time for that. Other than that, they might be able to give them another 30 days. And then accreditation periods can be extended to accommodate any changes in how soon you get reaccredited. Next slide, please. Let's talk a little bit about what we've seen just last week for a virtual validation review. For those of you that are health plans, you know how large that review is. It's usually 3 reviewers. They come on site for 1.5 to 2 days. In a blink of an eye, URAC and our client turned it into a complete virtual review. So how did they do that? Well, they expanded the reviewers to 4, and they did it for 1 day. So every reviewer had their own webinar, and the agenda identified all the things that that reviewer was going to do. So in 2019, IHS became certified by URAC, and since we're a virtual company, there was nowhere for them to go and visit, so they did the review completely virtually. So our team came up with this process, and it worked really well. Our client from last week used this format, and swimmingly well for them. URAC was very complimentary on how smooth the process went, given all the various moving parts. So as you can see in this column here that speaks to the activity, that's the review that's going to be done. That's the topic of discussion that the URAC reviewer will be doing, either doing a file review or interviews or looking at documentation. So in this column, you'll identify all the activities that are listed on your validation review agenda. The next will tell you the participants who should attend. So URAC's telling you it should be your applicant leadership and selected staff. And then we want to assign these specific activities to responsible folks. So who are the staff that are going to be responsible for doing the overview of your organization? And then any documents that help support, we ask that you link it to your agenda. So then for that day, you're never moving from the agenda. You're always using the links. We used Google Drive to have all of our information. I've seen the client last week put everything on a shared drive in folders and then link them that way. So it works really well. If you're interested in getting a copy of this template, we're happy to share it with you. Can you move on, Tom, please?
I can. Hold on a second. You bet.
While Tom's moving on, let me talk to you a little bit about the on-site review process. If the program that you're seeking accreditation for has an on-site component to it, new applicants, they will reschedule that on-site component. But if you're a reaccredited organization and you've had your virtual component already, then they will waive the on-site observation for this validation review. So that's a good thing to evaluate with URAC and speak to them about for this accreditation cycle if you're impacted by it. And then next, I'd like to speak to you a little bit about the ACHC, which is the Accreditation Commission for Healthcare. They are postponing all surveys in states that have greater than 500 reported cases and where there's a shelter-in-place order in effect. So again, any state with greater than 500 reported cases and where shelter-in-place is in effect. If you go out to their website, they have a link to CMS website that lists all the states. There's a map of the states, and it tells you who has what number of cases. They are suspending recertification surveys for home health, hospice, renal, and DemiPost. And for those of you that are accredited by ACHC for specialty with DemiPost, that would impact you. They still are conducting some initial surveys for providers, and providers is ACH term for their accreditation applicants. So that's what that's speaking to. If you feel that you can have your survey and you want to have it, you can outreach to ACHC, and depending on the specific circumstances, they may be able to accommodate that survey. For specialty and PCAP, for pharmacies that do not require DME accreditation as part of that review, they might be able to do it virtually. So outreach to ACHC and they'll work with you on the virtual piece. There are no fees for clients postponing their survey if the surveyor has not traveled to your site. And then surveys will be rescheduled when authorities deem it safe to do so. That's the question that we are getting from a lot of our clients. When do you think they're going to begin again? And as I mentioned, like for URAC, which gave the deadline of May of when their changes are in effect for, I'm guessing that that may change depending on what's going on with and what guidance we're getting from our leadership. You can see on the slide, we also have a link to ACHC, and on that website, they have FAQs, they have links to CMS. There are a lot of good links for you to get information on COVID and what the current policies are in place. Tom, can I turn it over to you to speak about NCQA?
Sure may. Thank you, Sue. You sure may. Thank you, Sue. NCQA, as is often the case with NCQA, has a lot of information. And so I'll only be able to cover it at a very high level today. But I'll begin with this grace period for annual requirements. What do I mean by annual requirements? First of all, there are annual requirements on how often you need to conduct certain analyses. There's annual requirements on certain member communications or delegation oversight activities. So that's what I'm talking about here. And what normally you would have, they give you automatically a 2-month grace period. So 14 months is your normal period. They've added 2 months to that. So now annual can mean within 16 months instead of what it used to be, which was 14 months in this unusual time. In addition, credentialing and denial and appeal files between March and September of this year are removed from any reviews going forward. So if you're struggling with that, then just know that this period of time simply won't count against you. Now, this is, NCQA is explicit about the documentation of disaster management plans for credentialing, utilization management, and case management. But what I'd say is that's really good advice across all of the organizations. Make sure that whatever you're doing is consistent with your disaster recovery and/or business continuity plans, and that you're documenting your response to this disaster the way that your policies say that you're supposed to be doing that. You don't want to get out of compliance with your disaster recovery policy in one of the great disasters of our lifetime. So make sure that you're in reference to that. And frankly, if we're going to find out if our disaster recovery policies are up to par, and we may need to revise them along the way if they don't accommodate this, which is clearly should be within the scope of your disaster recovery. But NCQA is explicit in its guidance about making sure that you document what you're doing with respect to credentialing, utilization management, and case management is consistent with your disaster recovery plans. Let's see what else we've got here. All right, if you now there's going to be a case-by-case assessment by NCQA of any leniency needs that are not described explicitly in their website, and you can apply for that. You just go into your home page, the NCQA, your myncqa.org page for that form. You should definitely be in touch. If your ability to go through the accreditation process in 2020 looks like it's being threatened, you should definitely contact your accreditation survey coordinator or your recognition account representative. You might need longer extensions or virtual surveys or shorter look-back periods, and NCQA is going to do that on a case-by-case basis. So you can go to their website or your homepage on their website and get the appropriate form for that. I want to talk very briefly about what many of us know as VIPS, but is the NABP Digital Pharmacy Accreditation these days. As of the middle of last month, NAPB suspended all of its accreditation survey and inspection activity. Now, they're going to continue to process new applications for accreditation and reaccreditation, but until we hear otherwise, NABP has really hit the pause button on its survey and inspection activities. So I'm going to toss it to Lesley to talk a bit about the Joint Commission.
So the Joint Commission is graciously following this theme of fluidity. And as of March 17th, they wrote on their website that they are going to suspend all regular on-site surveys of hospitals and other healthcare organizations. In some cases, there might be a small number of surveys that will continue, such as high-risk situations. At this time, the Joint is saying that they don't have an anticipated restart date. So there's that theme of fluidity. All postponed surveys events will occur once normal operations are resumed. And then if any organizations go past their accreditation, this is really important. So they're going to go past their accreditation due date. Accreditation will be extended without disruption to their accreditation status. And CMS has assured that Medicare payment statuses won't be affected by this. So that is great news. I know that we have a question, and in our next section, how the AOs navigate their inability to comply with some standards because of the COVID-19, we're going to address that question that's in there. So I'm going to pass it to Sue to start talking about how URAC, how we address URAC from that perspective.
And Sue, before you get started, I want to dovetail with what Lesley just said for our viewers. Please do take advantage of the question box that you should be able to find on your screen. It's either at the top or the bottom of your screen. It says Q&A. You can put a, or should say question in there. So if you do have a question, go ahead and post it there, and we'll get to it either as we go through this or in the question and answer period at the end. We encourage you to ask us questions. Now I'll toss it to you, Sue.
Okay, great. So URAC has come up with this lovely form. It's called the COVID-19 Temporary Noncompliance Documentation Template. And they are expecting you to add information. As you can see, they want the URAC standard number, the standard language, a summary of your temporary noncompliance, when that noncompliance began, when did it end, and what was the resolution? How did you, what did you put in place to be able to resolve that? Now, one of the questions we got was related to phone metrics. Well, you'll be happy to know, Tom, if you go on to the next slide. For the telephone metrics, there is no review of metrics between March 1st and July 31st, 2020. So again, for those of you who are worried about your phone metrics, your average speed to answer, abandonment rate, blockage rate, know that URAC will not be holding you accountable for those numbers for this time period. From a perspective, there will be no review of files between March 1st and July 31st. So again, giving you some leniency to be able to deal with taking care of those patients and making sure that you're doing the best that you can with what you have in place at that time, given this emergency. A couple other things I wanted to mention about URAC before I turn it over to Lesley to go on about HR is that if you are in the process of seeking accreditation from URAC, they are giving extensions without fees. We recently had a client last week who there was no way they were going to be able to meet their due date for submitting their desktop review of April 1st. So they requested May 1st. So they requested an extension from URAC. URAC gave them 30 days without a fee and let them know that if they're still in trouble and still need initial time, to please reach out to them again and they will consider a second extension. The same way with your accreditation and certification expiration dates, URAC will evaluate the need to be able to extend that should you be expired during this time period because you couldn't have your survey done. So just keep that in mind as well. And then to go back to the form, just 1 second, Tom, I forgot to add that URAC is also asking you to include any state or federal accommodations and relaxation of healthcare regulations on the form as well. So for your specific state, if there are any special rules in place, make sure that you're including that as well. So for instance, CMS has a lot of relaxation for some of their Medicare plans and things like that. So if you were a Medicare plan, you would put that on their form. Okay, let's turn it over to...
One way to think about this is, in addition to documenting on the form, don't simply rely on the form for your documentation of this. We can't stress the need for appropriate documentation enough. It's not unlike, as I think about it, it's not unlike the documentation required for a corrective action plan, where you describe the situation, describe your response to the situation, and then document your response to the situation so that when your accrediting body, whether it's URAC, NCQA, ACHC, VIPS, or the Joint Commission, looks back at this period of time, they'll be able to see that what you in fact did and why you did it. That's going to be really important as they, 5 or 6 months from now, let's say, they're trying to sort out what happened with their accredited organizations. It's not the getting rid of all requirements. It's just building flexibility in where that's needed, and where that's needed is the key piece. So your responsible use of documentation to make sure that you're tracking all that you're doing is going to be essential as we go down the road.
So let's move on to our questions. There's 2 questions, Sue, and one is somewhat related to that. If you wouldn't mind taking a look. The first one is, just to confirm, we won't need to complete the non-compliance form as long as the phone metrics concerns are within the time frame, correct? I mean,
I would advise you to still document on the form, just to have clear documentation of when it started, when it stopped, in case they come back. But they will not be evaluating those metrics during that time period. But you know, I always I'm always cautious and risk adverse. So I would tell you, yes, I would still, Tara, respond to that as well, document it. And then as far as the review of the UM files, is this for both UM and workers' comp UM? The answer would be yes.
Okay, thank you. I'm going to address the HR employment screening section. So first of all, URAC has relaxed requirement under the pharmacy standards. Staff are required, if they touch PHI information, to have background screenings, and if they deal in any of the dispensing of medications or are around the medications, they actually have to have drug screenings. This used to be required, or this is required in the standard, to occur prior to their hire date, that the screenings would occur prior to the start date, but URAC has relaxed it to say that it needs to occur within 60 days of hire. But let me just reiterate, for all of the standards, all of the modules that require primary source verification prior to the start date, which really URAC regards as prior to the hire date, for staff whose job descriptions require licensure verification, that has not been relaxed. You still need to primary source verify licensure for those staff whose job descriptions will require primary source verification prior to their start date. Next slide, please. Credentialing. So the URAC has relaxed their time frame requirements under the credentialing standards. So the credentialing standards can be found in the health plan, health network, and credentialing modules. And these standards require that applications are collected and signed by attestation within 180 days. And they've now been relaxed to be collected within 210 days. So prior to going to committee, the signature can now be 200 days old. And then for the collection of primary and secondary source verification, similarly, where it used to be 6 months, it has now been relaxed to 8 months. So the collection can now go to committee if it is 8 months old. They're also allowing for organizations to have their delegation oversight, the file review that has to be completed on those that are contracting to complete credentialing file reviews on their behalf. They're delegating that information. The requirement is a review at least every 3 years of those files. And URAC is saying if you have anything scheduled now, you can now postpone it and schedule it at a later date. So the standard requires every 3 years. I know that some states are requiring it every year for some programs. If that is your policy, or if you're missing your 3rd year anniversary date, URAC is relaxing that. And then finally, they are also increasing the period for the re-credentialing date, which is usually 36 months. They're adding 90 days to those 36 months. I've been getting some calls asking about, what do we do about credentialing? These are great relaxations, but really we can foresee URAC, our credentialing program coming to a halt for even 6 months. People won't have the staff in the provider offices showing up to be able to forward the files for credentialing. Providers are going to be treating patients and not having the time to really get the information to us in a timely manner. How do we handle this? And my answer to you is that we've seen this happen in Louisiana when there was the big hurricane, more recently in Puerto Rico. And all we can say is when things go awry, document when that date was. So I'm reiterating what Sue had talked about documentation and Tom do. We want you to document when things went awry and come up with some kind of action plan for when and what you will do when the time comes to going back to the norm of re-credentialing these providers. Those clients in those hurricane areas, what they did was they brought along these providers back as initial applicants so that the clock restarted ticking as initial applicants when they could get to credentialing. Again, come up with an action plan, have your committee bless it. You can't really come out with a time frame right now for when you will start doing this, but at least you'll have that. And our other clients who went through this were able to meet it because their action plan had this date in it, and then URAC was able to come back and say, okay, it happened for this 6 months period, and now we can see when you have started back up and are compliant and have been implementing compliance for so many months. So when things go back to the norm where you can start collecting this information back, it'll be important to document that time frame as well. All right, Tom.
Thanks, Les. We have a couple of questions here. First of all, will the webinar be available after this discussion today? And the answer to that is yes. We'll be editing and or just cleaning up and sending out a link to the video of this in the next couple of days, certainly by early next week, to everybody who's registered for this call. So thank you for that. The next question is, how do I obtain the temporary non-compliance form and virtual validation form? Contact us. We'll give you contact information at the end about our template validation form. The temporary non-compliance form is URAC, I believe, Sue, isn't it right that that's at your AccrediTnet site? I think you get that from your own AccrediTnet site.
Yes, I believe so, Tom.
I think that's where I got it from ours. So just log into AccreditNet and you'll see it on the, in fact, I remember now where it is. It's under the resources page of your home AccreditNet site. Let's see, we have a question. Sue, this looks like it might be for yours.
Okay.
Oh, no, this is actually for you, Lesley. The Workers' Comp accredited organizations, the change before hire to within 60 days of hire apply, or is this for farm accreditations only?
I apologize. It's for all clinical staff who have this within scope of their accreditation.
Great. Excellent.
Did you
now we'll bounce it to you, Sue, to talk a bit about ACHC.
All right. I am only aware, though, of the background check and drug screening being in the pharma standards. I don't know that they are also in the workers' comp standards. So
I agree with you. So the primary source verification, again, has not been relaxed at all. You still have to verify it prior to the start date. It's really just for the background screenings and drug screening, which really has been within the pharmacy modules.
okay, so let's talk about any accommodations that ACHC is doing for their accredited organizations. For those, like if you have a specialty accreditation with ACHC and your staff is required to wear protective gear while they're in the home of the patient, you may not have access to all the protective gear, given the shortage and what's going on. So one of their FAQs addresses what happens when the best you can do is the best that you can do. You only have the best available method in order to provide protective gear. It might not be the special masks. It may be a homemade mask. So what do? ACH's recommendation is for you to document. Common theme. So identify what was your rationale to move from a compliant process to the best that's available. Why did you have to do that? And then note the date of the decision, and then finally what you're going to do about it. How are you going to, what are your plans to get back into compliance? Well, in that instance, it's when the protective gear is available to you. So just making sure that you have everything well documented. And for those accreditations that ACHC has in place that require home health aides to be observed by a registered nurse every 2 weeks, that has been waived. They are strongly recommending, though, that you do a virtual supervision. As I indicated before, their FAQs related to COVID are like a few pages long. They also have many, many links to various agencies, including the CMS link. So that would be a good place for you to go. Okay. Next slide. Les?
So the Joint Commission's website doesn't have that much information. When we reached out to try and research what they're advocating, really, they're saying that they're available to help the accreditation organizations develop an appropriate response to COVID. But what they are advocating on and what they're really addressing, and there's tons of information about it, is their website is focused on hospital safety in the COVID environment. So they're giving a lot of information that they are providing, but that's really where their focus is right now, rightly so. Okay.
Excellent. I think I'm going to dive into NCQA now. And again, go to the site and get all the details there. They've got another enormous amount of information about both HEDIS and CAPS and how the response to the pandemic is affecting both of those and what to do about it. NCQA has decided not to do any health plan ratings for this year at all. So that's off the table. And then there are a whole set of special rules that apply to this time frame that starts last month and goes through September. Probably will be revised if it needs to be revised, but so far it looks like March through September. And I'll just touch on a few of the highlights of those rules. First of all, there's no need to credential. Let's say you've got non-PAR practitioners providing care as a part of a governmental response, emergency response team. You don't need to credential them at all, nor do you need to credential participating providers as a part of your own emergency response team. Now, again, and this is where, forgive us for sounding too repetitive here, but you really must document all of these decisions along the way. We understand this person's not credentialed, but he's under a part of this emergency response team, and so on.
And just to be clear, Tom, this is a CMS 1135 waiver, and that is just for those states in which this transfer is waived. So not all states are being given this waiver, but if you are in a state that's given this waiver, you can accept a provider from another state. You can primary source verify. You still need to credential them in the state in which they are licensed, but they can still practice in your state if you got that waiver.
Right, although that's a separate issue here.
Oh, sorry.
It's the CMS 1135 is a separate, distinct accommodation in addition to the no need to credential the practitioners involved in emergency response teams. Yeah, the CMS waiver deals with that whole issue about whether you can use providers from other states who aren't licensed in your state if they're otherwise would be required to be licensed in your state, as Lesley said. So now if let's imagine for a moment, as is the case in many cases, that there's something about your state's or the federal government's restrictions on activities that prevent compliance with an accreditation standard. There will be no penalty whatsoever if that is the case. And again, document that and here's something that we've seen, because this is actually a general rule among all accreditation organizations. State or federal law prevails over a conflict with the accreditation standard, whether it's NCQA or URAC or Joint Commission. Laws, in the rock, paper, scissors world of law and accreditation, law always wins. But don't just assume that because there's a law on a topic, or in this case, a governmental restriction on a topic, that's actually preventing you from complying with the standard. So the burden's going to be on you, as it is even outside of a pandemic time, to document that, in fact, you couldn't comply with the accreditation standard because of this law or this regulation, or in this case, of this state or federal restriction on activities. So again, we have over the years, in application of this general rule, seen instances where our clients, or even back in the days when we were reviewers, they would say, oh yeah, well the state law covers this. Well, that might be the case, but if the state law doesn't prohibit you from complying with the standard, just because there's a state law or federal law or activity restriction on the topic, doesn't mean that you actually can't comply. So again, documentation is going to be really important. Now, NCQA said it's going to apply flexible scoring to those instances where you just can't comply. It's even setting aside the existence or non-existence of governmental restriction. If your response to the crisis simply requires you to suspend compliance with a particular accreditation requirement, then document it, and NCQA has said on its website that it will use flexible scoring so that you're not improperly penalized for that kind of necessary choice. These next 2 points I already covered before. The annual requirements grace period gives you an extra 2 months. They're not going to cover the credentialing, and case management files in this time frame. And then on resumption of credentialing, you're going to be able to extend your re-credentialing cycles by 2 months to 38, and the provisional credentialing status from 60 to 180 days. And you can see that the URL at the bottom of this slide to go to NCQA's COVID page. Really encourage you to go there. It provides all sorts of detailed flesh around the bones that I'm presenting for you today. Again, I'll invite your questions on this last set of accreditation issues that we've talked about. We'll still answer them. We're going to have some time after we finish these next couple of sections, but so please continue to post your questions and we'll address them all if we know the answers. And then we'll ignore them if we don't know the answers. So telehealth. Telehealth is coming up in the news a lot, as you no doubt have noticed. So for example, CMS had already, even before the president's emergency powers were invoked, in fact, before we realized what was going to happen here, or at least many of us realized what was going to happen here, CMS was already, after many years of not doing this, recognizing telehealth and paying for telehealth services in rulemaking that it did earlier in the year. Well, they doubled down on that at the end of March by adding, under the president's emergency powers, 80 new services that are allowed to be furnished under Medicare via telehealth. And you can, when we send you the slide, you'll be able to click on that link and go to the site where there's much more detail on what are those 80 new services. So please go look at that. We also wanted to refer you, both NCQA and URAC have on their websites, they have special telehealth websites separate and apart from the COVID website. So we'll provide you with the links to the NCQA and URAC telehealth sites as well. We also invite you to look at your state regulators and see what they're doing about this. If telehealth is of concern to you or of interest to you in terms of helping your organization navigate the situation, you are likely to find that your state regulators are responding as well. So, for example, you see on the slide I've provided you with Pennsylvania's approach, one of Pennsylvania's, I'm sure several approaches to allowing healthcare professionals licensed under any of the Bureau of Professional and Occupational Affairs licensing boards to provide services to patients via telemedicine during the coronavirus emergency. That's an expansion of the previous allowable scope for the use of telehealth. And you're likely to find that in many states across the country. Now, we're just teasing this a bit here because it is a big topic. And we're going to be hosting sometime in the next few weeks. It's either our next webinar or the one right after that. We're going to focus exclusively on telehealth. And it's going to look both at telehealth and COVID. We're going to go more deeply into the weeds about the dance between federal regulations and state regulations and COVID and telehealth. But we're also going to look at some non-COVID telehealth issues and pay particular attention to accreditation. Those of you who have been tracking it will know this, but several years ago, URAC created the first telehealth accreditation, at least of which I'm aware. So that's been on the books for a while. And then URAC acquired from another accrediting body a whole suite of telemedicine accreditation programs. So now URAC has a comprehensive suite of telemedicine and telehealth programs that can be customized to your particular situation. That the original telehealth accreditation program was sweeping and comprehensive, and there's a lot going on in telemedicine that would not have met the rather rigorous requirements of that broad and sweeping telehealth accreditation program, but could be covered under any of the new more targeted telemedicine programs. So we'll cover that in greater detail by a lot than we are today. So we invite you to keep your eyes open for our emails announcing that. My guess is that'll be within the next 3 or 4 weeks or so. And then finally, we want to at least allow some space for staffing issues. So I'll toss this to you, Lesley, to talk a bit about staffing.
So we know that we're going to all start suffering from some staff shortages. Let me first just address clinically. We've heard across the board some states calling for clinical staff who've retired in the last 5 years to please join in. and come back and help in the hospitals, in the provider offices. And so we just want to encourage you to check your state boards of licensing rules regarding this allowance of retired staff to provide care. Usually they'll expedite licensing and they'll waive the fees. And again, just they are typically limiting this just to those who've retired in the last 5 years. I feel like we have been discussing this amongst ourselves. We're going to start feeling the squeeze of our staff really starting to dwindle down a bit. And we wanted to let you know that IHS is here to support you in your accreditation efforts, in those roles, if we can, in these times. Your staff may be switched into other areas of operations, and you might need some help in compliance and quality management. Just know that those are roles and areas that we can help. You can lean on us, and we can give some project management at that time for you. We're also here for ongoing compliance maintenance. Maybe you can't afford to have a resource in that area at that time to maintain your accreditation status. We have programs, we have staff that can help you ensure that you're going to maintain your accreditation standards while you're going through this time. And staff training. We can give one-on-one webinars, face-to-face webinars, or we have our platform called AccrediTrain that we have decided to change our fee structure a little more favorable now for those who have really a voluminous number of staff who are trying to get trained in URAC standards that are applicable to their jobs, which is one of the standards that are required. So we have a lot of resources that you can lean on us to provide to you. Soon you're going to see on your screen from this program a set of 3 questions in our polls. And we'll encourage you to please take the time to answer the poll questions. And there they are. Last time they came in 3 separate questions. Now they're all in one section. We'd appreciate if you could help us by answering that poll. You're also going to see well, I'm going to pass this on to you now, Tom, to talk about the next steps.
Sure. I'm putting our contact information up on this last slide. Please do reach out to us if you have any follow-up questions or need for additional, perhaps some of the staffing services that Lesley talked about. I will flesh out the AccrediTrain information. We have just changed the pricing structure. It's been the same $35 per seat ever since we launched it. And what we've decided to do is lower that fee for any of our contracted clients. So if you're already a client of ours, the fee is going to be for the first 50 employees, it's going to be only $30 a seat. And then another $5 break for employees number 51 through 250. So it's $25 per seat for that clump of employees. And if you're an over 400, over 250 employee company, all of the employees beyond 250 are going to be for $20 per. So if you've been on the fence about using our online training services, we've made some technological improvements. It seems like every year for the last several years, and have just completed a batch of improvements that allow us to service our larger clients more easily and fully, and at a lower cost. So I invite you to think of that if your training resources are stretched. But really, way beyond training or staffing, if you have any further questions about topics we've covered here or healthcare accreditation by any of these accrediting bodies, know that we work a lot in the URAC world and extensive NCQA and ACHC VIPS and experience as well. A little bit of Joint Commission, but that's kind of a new specialty pharmacy world. So we have some experience there, although certainly not as much as we have in the world of URAC. So please do reach out to us, and we hope to hear from you soon. Thank you for joining us. And as a reminder, this recording will be available to you as well as the slides themselves. Take care.